Thank you for having me, first of all. Yes, I'd like to talk about the development and implementation of the INFORM guidelines for treatment and management of prosthetic hip infection. I'm assuming that most people will know what prosthetic hip infection is in this audience. First of all, conflicts of interest. We've received NIHR funding for the INFORM program and follow-on development grant. Prosthetic joint infection is perhaps the most devastating. Some people call it a complication. I think it's better to call it a condition following primary joint replacement. It has a 1-year mortality rate of 4.3 and a 5-year mortality rate of 21%. And for perspective, that's higher than 3 of the 5 most common cancers. Approximately 8% of patients will become reinfected within 2 years of revision surgery. And following that reinfection, the chances of reinfection again increase. The psychological burden of prosthetic joint infection is also thought to be more than twice that of some cancers. 58% of patients experience depression and anxiety, and that is lasting, so that lasts for years after treatment. Our previous qualitative studies have also highlighted the psychological impact on patients, psychosocial impact, really. It affects all aspects of patients' lives. And those are some of the papers that we've produced looking at the impact of infection. So just briefly, the psychological impact on patients. These are some of the quotes from those qualitative interview studies that we did. And it talks about the sort of vulnerability and powerlessness that this leaves patients with. So one patient, Anthony, was on long-term antibiotic suppressants, which is one way of treating infection if it's thought that revision surgery won't work, or if the patient's preference is for non-surgery. It isn't physically limiting, it's the awful feeling that it's there and could well be terminal or degenerate into a terminal condition. It's insidious, and that sort of affected him. He said he feels much degraded by the fact that it's there, and he can't really do anything about it. Maggie described the psychological impact and how it led to sort of suicidal ideation. And she describes it well here. She said, your life's destroyed. There's nothing you can do about it. You lose your privacy, dignity, independence. You have no life. And for someone like me who lived a very physical life, a very gregarious person, she would have happily ended it all. She talked about she talked about it a few times in the interview. And she said it became very much a day-to-day, hour-by-hour existence. So the impact on social roles and work. So obviously people with joint replacement, people have joint replacements, and they're usually 45 to 50 onwards. So some of them are still working, and for those, it can mean that they are disabled essentially. And Jim was a bricklayer, and after the breakdown of his relationship, which I think was also related to prosthetic infection, he ended up living in a static caravan. And he couldn't work, obviously, because he wasn't physically capable of working anymore. And so the pressure is that no money, he can't get a job. If he knew he could get back to building, then he'd be happy. But he spends quite a lot of time in bed. He said, that's the only way I can cope with it. Better just to go to sleep and then the day's gone. And it affected his very character. He said, I got hardly any concentration anymore. I snapped quite quickly. Used to be very proud, placid. And essentially, you got a brain trapped inside a useless body. And then following sort of treatment, there's always that fear of recurrence for patients. So they live in a constant anxiety that the infection's going to return, which will mean more radical surgery and in some cases amputation. And Lorna said, I never quite trust it because the organisms can sit dormant. And if it gets sore, she panics in case it's the infection returning. And then it would be leg off time. That's what a surgeon told her, that she can't afford to get another infection or else there's nowhere else to go but amputation. And that was the same concern for Roger, who said, I'd rather die than lose my leg. So the INFORM programme ran from 2014 to 2020. It's an NIHR research programme, and it included lots of different studies, multiple systematic reviews to understand risk factors and effectiveness of treatments. There's an analysis of the National Joint Registry. We led developed and led the first RCT of one-stage versus two-stage revision surgery. That was particularly challenging, but we managed it. We also ran discrete choice experiments to understand patients' preferences for treatment. Health economics was built into the randomized controlled trial, and we also ran qualitative research with patients and clinicians to understand the impact of infection. And over the course of that program, we produced 34 peer-reviewed manuscripts. And so the problem after that was, how do we get all this evidence into practice? The aim of the program was to improve things for patients, but unless we can put that evidence into practice, then we haven't really reached the aim. And so we applied for further program development funding to implement the INFORM evidence by developing and implementing best practice guidelines. And that ran from 2021 to 2023. So study one was to work with expert stakeholders and develop these best practice guidelines based solely on the evidence from INFORM. That's important for later on. And to implement and evaluate the guidelines in 12 UK orthopaedic centres. And then to use the feedback and evaluation from the implementation to develop resources and enable further rollout. So just to say that there are no other evidence-based guidelines for prosthetic joint infection. The BOA, the British Orthopaedic Association, has guidelines. They have the BOAS guidelines, but they're not underpinned by evidence in the way that these have been. And so study one, developing the guidelines, we took all the evidence from the 6-year programme, we distilled it into a draft guideline amongst the research team and patient participants, and we did a consensus survey with 20 UK experts in prosthetic joint replacement and treatment, and that included surgeons, GPs, physiotherapists, rehab experts, other academics, commissioners, and patients. And we used the modified nominal group technique to refine and agree those guidelines. They were eventually published in the Bone and Joint Journal in 2023. And so from then on, we've been working to sort of further implement those guidelines. These are the guidelines. Those orange boxes are just to sort of highlight the things that I think are applicable to this audience in particular. We envisioned that the guidelines originally would be mostly for orthopaedic surgeons. It's only through the implementation work that we realised just how important they are for anybody that manages patients who've had joint replacement and prosthetic infection. So I'm just going to go through these briefly. So hip replacement patients with post-operative complications such as slow wound healing or unexplained pain should prompt high suspicion. Modifiable risk factors should be optimized. Diabetes, particularly important, smoking, things like that. Before revision treatment, those need to be controlled. Diagnosing infection, all patients with persistent fluid discharge, worsening erythema, worsening pain arising from the joint should be investigated for infection. Any patient within the first 4 weeks of primary joint replacement with increasing discharge, reduction in function, worsening erythema should prompt discussion with a specialist orthopedic colleague within 48 hours. A patient with a previously well-performing hip replacement who develops symptoms consistent with infection, such as those same symptoms which persist for more than 48 hours, should prompt discussion with an arthroplasty specialist within 72 hours from presentation. So the previously well-performing relates to late-seeded infections. So they can be through dental work or injury, months or years after the primary. Improve education and patient and clinician information to enable earlier recognition of signs and symptoms of infection, and increase vigilance among primary and secondary care patients at high risk of periprosthetic joint infection. This includes optimizing an open door policy to allow patients to be referred back to the treating orthopedic team promptly. The other sort of sections there are on the actual surgical treatments. So the last section is on post-operative management, also relevant. Patients need appropriate levels of patient-centered rehab as determined through assessment from early on in the journey. Patients with infection should be asked about the need for psychological and social support, and this offered from the point of diagnosis to long-term recovery. Patients should be assessed and provided with appropriate aids and equipment to support their recovery and rehabilitation. All these things have an element of primary and community care within them. Patients should remain under the care of an infection multidisciplinary team whilst on antibiotics and monitored for side effects and tolerance. So those are the guidelines. Study 2 was to implement the guidelines and develop resources. So we implemented them within 12 UK revision centres, those centres that have a particular excellence in treating prosthetic joint infection. We implemented them in 2 waves of 6 months. So one wave, and then we'd take learning from those 6 centres and apply them to the next 6 centres. And we had an online WhatsApp discussion group. We call it an online a learning collaborative. And that was to discuss the guidelines during the implementation process and try to understand learning and feed that back in as we went on. And then I conducted interviews with 17 members from those UK revision centres to understand how the implementation was going. We use thematic analysis to understand barriers and facilitators. Now, just to sort of cherry pick some of those barriers and facilitators, ones that I think are relevant. Knowledge of the guidelines was limited to surgical colleagues and MDTs. What we'd hoped is that surgeons would disseminate those guidelines widely throughout their teams. What actually happened was that a lot of the surgeons within these centres, you remember I said these are specialist revision centres, they're already working to those standards. That's what they said to us. And so they felt less of a need to spread them throughout the MDTs, because they felt that all their MDTs are already working to those standards. So they're less motivated to share them. However, when we spoke to other members of those MDTs, such as the physiotherapists, they said, this is the first time I've seen these guidelines prior to the interview. Our orthopedics colleagues have not shared these with us. And so they said they would absolutely make a difference to the way we deal with patients, and this should be shared more widely to GPs, physiotherapists, district nurses, community physiotherapists, and on emergency departments, etc., to facilitate early identification of PJI. One particular physiotherapist that I spoke to said it would change the way they referred patients, because previously they would have referred them to the GP for antibiotics, whereas now they know they should refer them straight back to the orthopedic team. Some of the sites suggested that between 10 and 20% of patients arrive having had preemptive antibiotics in primary care or suboptimal treatment at non-specialist units. So it used to be more so than now, I think, that surgeons were tempted to have a go at dealing with infection and treating patients with suspected PJI. Partly because they thought that they could do it, but also because there was a stigma attached to the fact that your patient has prosthetic infection. And there's a temptation sometimes to not hide it, but not refer it on and try and deal with it yourself. The major revision centre network now has been set up to ensure that doesn't happen and that patients are referred on to the major revision centres who have the expertise to deal with these. However, in primary care, depending on the relationship between the revision centres and their primary care networks, there are still patients that come back having had preemptive antibiotics. As one orthopaedic consultant said, if you're looking to do the maximum good from these guidelines, the place to do it is in those setups because they're the people who are going to do the stuff they're not meant to. So that's referring to sort of primary care and non-specialist units in particular. Tackling psychological support for patients. So while surgeons said they were working to these standards already, the one thing that none of those 12 centres could implement was psychological support for the patients, yet they all agreed how important it was. And the reason for that was that there was no funding or resources to implement it. NHS talking therapies was tried during the course of the implementation, but they found that it was poorly signposted, oversubscribed, and had long waiting times. And a lot of the consultants felt that it wasn't suitable for patients anyway. Other things that were tried was piggybacking on other trauma services, but that was unreliable. And the fact is that a lot of trauma centres don't even have psychological support for their patients anyway. One quote was, the only thing that we haven't been able to comply with is psychological support because we don't have any psychological support in the region, full stop, at all. So this is something that we're working on now to try and remedy that. Advanced orthopaedic nurse practitioners and MDT coordinators within those centres were seen in some ways to be bridging that gap because they could provide a consistent point of contact for patients, which reduces the anxiety and uncertainty that a lot of patients feel, and they provide reassurance and key information throughout the treatment pathway, which can be years. So if a patient has, if they have a one-stage revision, it can mean that everything is done in one operation and the recovery can be sort of, 3 to 6 months. If it fails and they have to have, go on to have another revision surgery, say a 2-stage, that can mean all the prostheses are removed. They can have an empty space, they can be wheelchair bound, that can go on for anywhere between 6 to 12 months before they have new prostheses put back in once they're certain that the organisms have gone. So it can be years for rehabilitation. Uncertainty is a major factor in patient anxiety, or anxiety causes the uncertainty causes the anxiety. And that in turn eventually ends up causing depression and all sorts of other things. So advanced orthopaedic nurse practitioners are seen to be bridging that gap in some way by keeping in touch with the families and letting them know what was going on. So what next in terms of identifying, implementing the guidelines? So we've tried to raise awareness of these guidelines beyond the orthopaedic MDT. So Remedy is a local online referral system that we have in the Bristol area. So we've managed to get the guidelines onto the Remedy system so that GPs can just look up infection, orthopaedic infection, it will take them to the guidelines. We've created quick guide posters for primary care and community clinicians to pin up on the walls that gives a quick breakdown of what actually to do if they suspect an infection. We've got the guidelines within local primary care GP bulletins, newsletters to the ATOCP, which is a trauma and physiotherapy society. Impact accelerator units have helped us to spread the guidelines through MDTs and primary care networks across the UK. We've done education sessions with local RSK physiotherapy work streams and the UK National Physiotherapy HIP Network. You'll have heard from Lucy Gosling earlier. And the Bone and Joint Infection Society, we've implemented these, we've spoken about these guidelines at different conferences. The Bone and Joint Infection Society, Oxford Bone Infection Conference, British Hip Society, etc. They all have good support from the audiences and surgeons, which is fantastic. Also on our behalf, John McDonnell MP submitted 4 questions to Parliament. We did get responses back. There's nothing really worth noting about the responses, other than that they're working on, improving care for orthopaedic patients. So it's kind of non-committal. I just wanted to play you a couple of films. So what we've done is also we've developed an implementation website, which explains the guidelines in context and why they're relevant for different healthcare practitioners. But also there are resources on there for patients, as well as clinicians, primary and secondary care. And these are some of the films that we've produced to help explain the guidelines. I just wanted to play you a couple which I think are relevant.
So the INFORM trial was a randomized trial looking at 1 versus 2 stage surgery. And what it showed is that 2 years after surgery, both patients who'd had 1 stage and patients who had 2 stage had very good outcomes. However, the journey to get there was quite different between the two.
So I think these are an important way of summarising some of the key things for colleagues in the community across a variety of different roles to be aware of and to look out for.
Problematic joint infections come from not seeing them. They come from popping up 4, 6, 8, 12 weeks down the line. That's when we have serious issues. If we have this open policy and we have these very, very clear guidelines that tell us exactly what to do when we see it, it will vastly improve the patient's journey. It will vastly decrease the need for revision surgeries, long-term antibiotics, further management, because we can get in quickly.
What I'm hoping with these guidelines is that by following them, patients will get prompt and effective care.
They are enabling those colleagues to access orthopaedic team members directly where they need to, which hopefully should speed things up. They've been developed with a range of clinicians and, really importantly, with patients.
We've all been through a different journey, and some have been very long, some have been short, but we all know what it's like to have that infection.
What we're very pleased about with the INFORM guidelines is that they are particularly based on the evidence garnered by the INFORM program. So we can be very confident that these are backed by good scientific evidence.
This isn't anecdotal research at all. This is very, very robust, collected and collated data that is informing these guidelines, and that's, in my opinion, why they will be set and they will be considered a gold standard for infection management post-operatively.
It is most common for infection to occur in the early post-operative period, so it's really important to be vigilant there. And if patients show sign of infection, it is important that they're referred promptly back to the operating team.
My then husband called the doctor, GP come out, literally took one look at my hip and said, no, you need hospital and you need to go now. And took me, and the ambulance turned up, and as I said, I was taken to French. and obviously they then do the blood tests to look at your infection level, and mine was sky high.
The reason it's important to treat it promptly is that bacteria form something called a biofilm, which is a protective shield around them where it's much more difficult for antibiotics to penetrate and much more difficult for the body's natural defense mechanisms to penetrate. So it would be important for us to try to treat it prior to the biofilm forming.
You couldn't get out of bed. You'd been awake all night with a pain in your hip. You couldn't get out of bed. I rang the doctor and the doctor came, and then you were taken to the hospital.
Yeah, not being able to get out of bed, and the doctor came and got me to the hospital, yes.
So patients who do unfortunately get an infected joint replacement, their outcomes will be different, their surgery journey will be different, their amount of surgeries will be different, but the really, really important thing is early access, early identification, early assessment.
Because speed is important at this point, isn't it?
Exactly. So if there is a suspicion of infection, then it's important that that person is seen and evaluated by the specialist team quickly.
If there is a referral for a patient who may have an infection who turns out not to have an infection, that's far preferable than a patient who may have an infection that isn't treated promptly and then does have an infection.
What I would say is, if you've got that niggle and you think just the slightest, if you're really unsure, go back to the hospital and get it checked.
What's really important in treating the infection is to try to identify which organism is responsible for the infection and which antibiotic would be best in treating that organism. So in order to do this, we try to get really good samples from deep within the infected tissue. If you give broad spectrum general antibiotics in the community, what usually happens is that it dampens down the bacteria but doesn't necessarily eradicate it. Then when we take our samples, the bacteria doesn't grow, and so we never know for sure what's the exact organism or what are the best antibiotics to treat it.
It's really important not to be treating these infections by yourself in the community. You're going to need the input of the specialist orthopaedic team urgently.
Because at the end of the day, like I said, if I'd gone sooner, the infection wouldn't have gone as deep as it did, which wouldn't have led to all the operations.
Sorry, I'm just going to share screen 2 again. So besides the website, the other thing that we've the other thing that we have created is an NHSE learning module, and this is for all healthcare professionals to understand how they can implement the guidelines, personally how they can recognize infection, refer patients in a timely manner, and that's CPD certificated. And there's a link at the bottom of that screen that you can access. And that's just been launched. So if you feel that your colleagues would benefit from that, please encourage them to do that. And this is just some clips of the Inform website itself. So if you go to Inform Bristol, AC UK, you will find various resources for clinicians, primary care clinicians, as well as secondary care, and the guidelines themselves, with videos for each section of those guidelines to sort of help understand the context and why they're important. There's also links there for patients and family, because we understand, that patients need help at sort of every sort of aspect of the journey. And they're also downloadable resources. So those things I mentioned, the posters that sort of encapsulate the main elements of the guideline that you can put onto clinic walls, recognizing prosthetic infection, what to look for, what to do, and sort of red flags. And there's also stories from patients. Depending on where patients are in their journey, you may find it helpful pointing them towards this website, or giving them sort of these stories from people like Sue and Vernon, just because it makes them feel that they're not alone in this, and seeing other patients have gone through this might give them a little bit of comfort, and to know that there are other people who understand what they're going through. And that's it. Thank you. And just say thank you to the Learning Collaborative that helped us to implement these, and the rest of the research team.
Thank you, Andrew, for sharing your presentation. That was brilliant. We have got a couple of questions if you're happy to take them. If a patient is immunosuppressed, how would you detect prosthetic infection?
You would have to ask a clinician about that. So I am non-clinical. So I'd not like to even attempt the answer.
Okay, thank you. Patient caught at the beginning of being feared of amputation, is that ever carried out, or is a girdle operation still performed?
No, amputations are still carried out. It's actually higher than I thought. The amount, I can't remember off the top of my head how many. But if you go to any sort of orthopedic conference, particularly Barges, the Bone and Joint Infection Society conference, if you're interested, is a very good conference to go to understand prosthetic infection. But yes, they are carried out still.
Okay, brilliant.
Thank you very much.